Aloha, everyone. We want to welcome you to the monthly Queen's Free Speaking of Health lecture series. Tonight's lecture is called Caring for Your Kidneys. My name is Sean Ibar from the Corporate Communications Department at the Queen's Health Systems. We have a packed show tonight, so I want to get to things as quickly as possible. Our doctors, we have two doctors this evening here tonight. First is Dr. Christy Izutsu. She was born and raised here in Hawaii. She attended the John A. Burns School of Medicine and graduated in 2011. And then she went on to do her internal medicine residency and nephrology fellowship at UC San Diego. She returned to Hawaii in 2016 and practiced at the Kidney Clinic of Hawaii at St. Francis. Dr. Izutsu assisted in the Queen's Medical Center Transplant Department, and she is also on the faculty at the UH School of Medicine. In her spare time, she enjoys spending time with family and friends. Our second presenter is Dr. Makoto Ogihara, who is originally from Japan. He came to Hawaii in 2000 and completed his surgical residency in Hawaii. And after a transplant surgery fellowship at Stanford, he returned to Hawaii in 2007, and he has been in practice ever since. He is a liver and kidney transplant surgeon, and he's also the director of the Living Donor Program of the Queen's Transplant Center. He also serves as medical director of Legacy of Life Hawaii. So let's first give a warm welcome to Dr. Izutsu and Dr. Ogihara, and Dr. Izutsu will go first.
Okay, can you hear me okay? All right, so tonight I'm going to be talking about the basics of chronic kidney disease, or the ABCs. This is sort of like the spiel I give to my patients in clinic. Hopefully, it's simple enough for beginners to understand, but for those of you who have either chronic kidney disease and have heard something very similar to this before, we'll go into a little bit more detail. So tonight I'll be talking about the burden of CKD in our community as well as the world at large, how to screen or detect chronic kidney disease, some of the most common risk factors, management of the early disease through diet and lifestyle, and then some of the options for medical management. So what's the burden of kidney disease in this world? It's really, really big. Okay, so there are 37 million Americans living with chronic kidney disease in this world, in this country. And then, there were at least 956,000 deaths related to kidney disease back in 2013. So, some of the statistics are still coming in. So again, some of my numbers may not be the most up to date, but even 6 years ago, the numbers are pretty staggering. National statistics, like I said, 37 million Americans. 1 in 3 adults are at risk for chronic kidney disease. So look to the person to your left and to the right. There's a good chance one of you either has or will end up with chronic kidney disease of sorts. 15% of women and 12% of men are at risk in this country, and it is unfortunately the 9th leading cause of death, and it is far surpassing cancer as a cause of death in America. There are over 700,000 Americans living with end-stage kidney disease or needing dialysis in this country. Opportunity for you to learn something about how to screen for kidney disease and what puts you at risk for it. So if you've got friends or family with some of the risk factors that I'm going to talk about, maybe you can shed some light on them as well. So more than 1 in 7 patients have chronic kidney disease. Again, a ton of people in this country, and like I said, 1 in 3 adults. Those 1 in 3 adults, usually 1 in 3 of those will have diabetes or high blood pressure, which is the 2 most common causes of kidney disease in this country. So the color doesn't project entirely well, but actually Hawaii down here is the lightest shade of blue. So while the prevalence is still pretty high, in part, we're doing a pretty good job of taking care of our patients and preventing them from developing chronic kidney disease as in comparison to other parts of the nation. So what are the Hawaii numbers? 4.2% of people in Hawaii had chronic kidney disease about 5 years ago. So again, about 46,000 of the 1.1 million people in Hawaii who actually answered this survey, and about half of them are middle-aged folks. In Hawaii in particular, the ratio is actually 1-to-1 male to female. So how do you detect kidney disease? It's actually pretty simple. You just need to see a doctor, or maybe you go to one of those health fair screenings, because we can do a simple blood test, and on the chemistry panel or some of the chemical tests to look at your blood composition, we'll notice an elevated creatinine. Okay, so creatinine, it's a number that we test for as part of routine blood tests. By itself, it's not harmful. It's just a molecule floating in your blood. Okay, it actually comes from muscle, which is why it sounds a lot like the word creatine. So if you've heard of those bodybuilders taking those creatine shakes or creatine powder, it's very similar. So creatinine comes from muscle. Our bodies make and break down muscle all the time without you even knowing it. And when your muscle breaks down, what happens is creatinine gets released into the bloodstream. Your blood circulates through your body, ends up passing through your kidneys, and the kidneys decide how to filter out toxins and keep the stuff that should be in your blood from escaping. What's supposed to happen is the kidney is supposed to filter and get rid of creatinine in your urine, such that people with well-functioning kidneys actually have a low creatinine level. Okay? Normal is going to differ between men and women depending on your muscle mass as well as your ethnic background. So I would give you a rough estimate of normal being somewhere between 0.6 to 1.2, but again, take that with a grain of salt because normal varies from person to person. In patients whose kidneys don't work, creatinine is not going to leave through the urine, and it's actually going to build up through the blood such that when we check your test, the creatinine level will be higher and higher. In conjunction with the creatinine level, you're going to notice a number called eGFR, and it's actually a mouthful of a word, or a mouthful of a term. It's estimated glomerular filtration rate. So how efficient are your kidneys filtering your blood? Obviously, the more efficient your kidneys are, the higher your eGFR will be. So I tell my patients creatinine's like golf. eGFR is like basketball, okay? The lower the creatinine number, the better. eGFR, the higher the number, the better. In terms of urine tests that we can do, it's actually quite simple too. Just like creatinine should be escaping into the urine, we'll actually test your urine for the amount of creatinine in it. We'll also test for protein, which should not actually be in the urine, but in certain patients with kidney disease, they actually release protein into the urine, and when we test regular urine tests, we can actually pick it up. So the term would be proteinuria, so urea meaning in the urine. Albumin happens to be a specific type of protein in your blood, or the most common type of protein in your blood, which is why we test for it. In diabetics, they tend to be at the highest risk for having protein in their urine. So when you go to a health screening or even to your primary care doctor, oftentimes when they ask you to submit a urine sample, they're looking for things like protein, blood, or even glucose or sugar in your urine. The presence of any of those molecules in your urine does suggest the presence of kidney disease. So this is what a normal chemistry panel looks like. You'll notice that creatinine is a little elevated in this patient. The normal range is actually being reported as 0.6 to 1.4, and this patient's creatinine is 1.5, so just slightly above the normal range. Then we compare it to the GFR. Note that the GFR is actually reported twice, but read the fine print really well, because I've had some patients come to clinic and tell me, why is my GFR 55 this time and then it's 32 this time? It's actually because they're looking at two different values. So eGFR gets reported for non-African Americans versus African Americans differently. And the theory behind this is that African Americans tend to have more lean muscle mass, and so they generate more creatinine. Likewise, their GFR actually isn't as low despite their creatinine being a little higher. This is just a sample urine test. So in fact, this patient doesn't have any albumin or protein in their urine. So this is what a normal urine albumin will look like. The other test we'll look at is the urinalysis, or a full analysis of your urine. So this is actually completed initially with a dipstick or a color indicator. So you'll submit the urine and a actual color indicator will be slipped into the urine, and we'll look at that, and that'll be the screening test. So we'll actually look for protein based on color changes of that indicator. If you look at the fine print at the bottom, we also look for cells in the urine, so white blood cells and red blood cells, which generally should not be there. And that, again, can signal any specific type of kidney disease. Once you go through the initial screening, most times we'll look at imaging studies or pictures of the kidney. The simplest test to do would be an ultrasound, so not invasive, meaning we don't have to inject any dyes or anything, and it has no radiation associated with, so not like a CAT scan. Sometimes people will be getting ultrasounds or CAT scans or MRIs for other reasons, and incidentally will pick up kidney abnormalities. Some people are actually born with one kidney, even though you're supposed to have two, and they'll never know until they're maybe being imaged for something else. Some people have kidney stones, and their doctor will send them for maybe an ultrasound or a CAT scan, and then we'll pick up some abnormalities there. And sometimes people are getting imaged, like I said, for a totally separate reason, and we'll pick up a joined kidney, a kidney that's abnormally small, abnormally large, etc. The most definitive diagnostic test available to us right now is actually a kidney biopsy. Not everyone will be recommended to undergo biopsy, so if you talk to your doctor, I don't actually recommend saying, hey, can I have a biopsy? Because let's be honest, if we don't have to stick a needle in you, we don't really want to. So a biopsy is just that. We actually stick a needle into your back and we take a very tiny piece of kidney tissue and look at it under the microscope. A pathologist or a specific doctor who specializes in looking at kidney biopsies will look at your biopsy under the microscope and tell us exactly what's going on with your kidneys. It's a pretty neat test, but again, I don't recommend it unless we recommend it. So where can you go and get screened? There are actually a lot of different opportunities to go and get screened. First and foremost, your primary care doctor. Usually they'll run routine blood and urine tests on you at least once a year. So I do encourage all of you to keep track of your urine and blood tests on a regular basis. It's easy enough to ask for a copy of your test results. The National Kidney Foundation that was outside actually does a couple of health screenings every year. So this is not necessarily a plug for them, but more just to give you opportunities to get screened, but they do offer kidney disease risk factor questionnaires. They'll do complete urine evaluations at some of their health screenings, and then in the past they've offered these urine test kits that you can take home and actually test yourself. Based on the results of the GFR and how much protein there is in your urine, we stratify our patient's kidney disease. So when you come to see a kidney doctor, we'll say, your kidney disease is stage 1, 2, 3, 4, or 5. Okay? The lower the number, the better your kidneys are functioning, which corresponds to the fact that you have a higher GFR. Okay? So most patients who come and see a kidney doctor or a nephrologist have kidney disease stages 3, 4, or 5, which means that the GFR is 60 or less. And the reason for that is when the GFR is higher than that, you don't tend to see a lot of the kidney-related complications that we'll talk about. But once you hit stage 3 and beyond, we start to see things that maybe nephrologists or kidney doctors are much more equipped to, or better equipped to handle. Then, corresponding to the stage, you also have protein stages. So we'll classify you as 1A, 2A, and 3A. And that tells us how much protein is in your urine. So now you want to probably know, well, should I be screened? Maybe. Some of the reasons that people will get screened is if they start to show some signs of kidney disease. So unfortunately, kidney disease is really non-specific, even in its early stages. In its earliest stages, you won't even notice anything. But as kidney disease progresses, you'll start to see things like fatigue. You just may not be quite as hungry. Some of my patients just say, my energy just isn't what it used to be. I figured I was just getting a little older. But then they come to see me and we figure out they do have significant kidney disease. And that sometimes does account for why you just have no energy. Sometimes patients will complain of leg swelling or they'll actually see blood in the urine. Kidney disease patients will also start to urinate more, especially at night. And this can be a little bit confusing because sometimes enlarged prostate problems will also cause people to urinate more at night. So again, some of the very non-specific findings in kidney disease, but things to just be aware of. So who gets kidney disease? Well, a lot of people, right? So the two most common causes of kidney disease happen to be high blood pressure or hypertension and diabetes. There are certainly other risk factors for kidney disease, including heart disease. Patients with kidney stones are actually at risk for developing kidney disease down the road because oftentimes stones can be large enough to block off the kidneys. When the kidneys get blocked off, urine, which is supposed to flow nicely into the bladder and out of your body, actually gets plugged up, and it causes a lot of back pressure on your kidneys, which eventually causes damage to them. Patients with rheumatologic or autoimmune diseases are also at risk for developing kidney disease, and the prime example would be lupus. So one of the most common complications of lupus is actually a lupus-related kidney disease. Patients with enlarged prostates are also at risk. Certain kidney disease do run in families, so that's also something to be mindful of. Lastly, smoking and obesity are also risk factors for kidney disease, as well as high blood pressure and diabetes as well. So think about these risk factors, and again, if you start to notice your diabetes, you do have diabetes or high blood pressure, it's a good idea to check in with your doctor regularly and make sure that you're getting routine screening done. So how do we manage kidney disease in its early stages? Well, it's as simple as me telling you to control your blood pressure, control your diabetes, exercise, and lose weight, right? Well, that's not necessarily as simple as it sounds. Work with your doctors, work with your primary care providers, your endocrinologists, your kidney doctors to improve these parameters. So getting blood pressure under control may not be really easy, but what I tell all of my patients is if you start measuring your blood pressure at home, it's a lot easier for us to adjust medications in clinic such that we can better address the high blood pressure and keep it under good control. Diabetes management starts with you, right? So choosing the right foods, again, really easy for me to say, not so simple to do in practice, but checking your sugars at home if your diabetes doctor instructs you to, keeping good communication with your providers and really making a solid effort really actually prevents early stages of kidney disease or delays early stages of kidney disease. Exercise is always a good idea for managing high blood pressure and diabetes, and it goes a long way for kidney disease as well. Losing a little bit of weight actually can make a big difference on your blood pressure and diabetes, so that speaks to the two biggest risk factors for kidney issues. Loss of 10 pounds actually can lower your blood pressure about 10 points. So that's something to keep in mind. And it's not to say that the more weight you lose, the lower your blood pressure goes. So if you lose 40 pounds, you're going to lose 40 points on your blood pressure. It's not that simple, but the first 10 pounds goes a long way. So my patients always ask, what am I supposed to eat? You keep telling me to watch my diet, do this, do that. I have diabetes, I have kidney disease. The only thing I can eat now is cardboard. Really though, if you look at the diabetes diet and the kidney diet, very few things intersect. So what I tell my patients is go heart healthy, okay? Go for things that you know your diabetes doctor would have encouraged, your heart doctor would encourage. As you develop more advanced kidney disease, then I start to chime in on kidney-specific things. So I usually don't force a kidney diet on my patients early on, but when you hit stages 4 and 5, that's when we start to see some of the lab complications of an uncontrolled diet. So my recommendation is usually low sodium, low potassium, low phosphorus, a moderate amount of protein, and reduced fluid intake. Super easy, right? No, it's really not. And actually, we're starting to send our patients out to dietitians now because we've noticed that when we give our patients instructions and the endocrinologist or the diabetes gives you separate instructions and you're trying to navigate this very complex diet, it gets incredibly frustrating. So we want to do everything we can do to help. In terms of kidney-friendly diet, so high potassium foods, okay, the big 5 are going to be your avocados, bananas, oranges, tomatoes, and potatoes. And for the local fans, things like breadfruit, taro, and coconut are big, high potassium foods. So if I tell you what not to eat, it's only fair that I tell you what you could eat, right? So some low potassium foods, which are just as appealing, if not more. So apples, grapes, pineapples, eggplant's a good one, broccoli, carrots, corn. So not everything is off limits, and if you look at this list, some of this actually coincides with the diabetic diet. High phosphorus foods. So phosphorus becomes problematic because it's actually high phosphorus that causes the cascade leading to bone disease in kidney patients. So what are some high phosphorus foods? All the stuff we love, right? So don't eat chocolate, don't eat ice cream, avoid the beans, no meats, no muffins. Great, right? Your diabetes doctor is going to be really happy. And you're going to be miserable. So what can you eat instead? Okay, this actually coincides a lot with the low potassium foods as well. So snacks like popcorn and crackers. Dark colored sodas are interesting because if you look at the label, there's actually phosphorus hiding in there. I tell my patients, they're not going to tell you all sodas contain phosphorus. It's going to be hiding as phosphoric acid, something like phosphate, triphosphates. So you got to read the labels really carefully. The only dark colored soda that doesn't count for this is actually root beer. Coffee and tea is also fair game for low phosphorus. So what about the actual medical management? Okay, what are you bothering to go see your nephrologist for, right? So I will tell you right up in front, and honestly, there is no magic kidney pill. If there was, I would totally be out of a job and I would be okay with that because no one would have kidney disease anymore. Unfortunately, it just doesn't exist. So what we do is we actually help to manage the complications of kidney disease. So first of all, blood pressure sometimes becomes a little harder to control. So we're pretty familiar with different classes of blood pressure medications. I've had patients that have gone through 5, 6 different ones before we settle on the right one. So don't give up. Sometimes it's a little bit of work just to get it right, but we'll keep trying until we do. Likewise, with hard to control blood pressure, some people will start to retain fluid in their feet or swelling. Sometimes that's a manifestation of high salt diets, but also sometimes protein in the urine can cause problems with retaining fluids in the blood vessels such that you start to get swelling in your feet. So, if you've tried the low salt diet and you've got some protein in your urine and it's still not going away, don't blame yourself. Come and see your nephrologist and we'll work with you on that. Compression socks are great. Water pills work better. Like I said, protein in the urine is a big problem in a lot of our diabetics. So there are certain classes of blood pressure medications, things like the ACE inhibitors or the angiotensin receptor blockers, or for ARBs or ARBs for short. We reach for those as first-line blood pressure pills, and they're fantastic. They actually are the most kidney protective blood pressure pills out there. And so we try to get our patients onto those medicines as quickly as possible. Unfortunately, that can cause some high potassium, so sometimes we have to be really strict about the diet when we put you on those medicines. Kidney acid tends to build up in later stages of kidney disease, so I actually give my patients a medicine similar to baking soda or sodium bicarbonate. If you've ever met one of my patients, I actually do give them baking soda. So sometimes I tell them, just mix a teaspoon of baking soda into your water and use that to take your pills instead of using regular water. I do not necessarily advise that for early stages of kidney disease because it's not necessarily going to help anything right off the bat. But if you do have high kidney acid levels in your blood, it is an option for you to take baking soda. Just don't mix it with orange juice because you're just going to kind of negate the whole effect. Like I said, the high potassium can be a real problem. So there are medications out there that we can prescribe now that actually will lower your potassium. So if you've been struggling with your diet, you've been really good, you've been trying everything, and it's still high, there are things we can do to help. There are medicines like Veltassa or Patiromer. We can give you water pills like furosemide or Lasix, and those actually help you to get rid of potassium from your body. High phosphorus can be a problem, and like I said, it triggers off this cascade of bone problems. And really, the way to control phosphorus is to keep you from absorbing it. So in later stages of kidney disease, my patients will be on a phosphorus pill that they take with their food. So when you eat your meals, all that delicious phosphorus that's getting absorbed by your gut, the pill will actually keep you from absorbing it. And then one of the other more common complications is anemia or low blood counts. So kidney patients, we all make a hormone called EPO or erythropoietin, but kidney patients tend to be pretty resistant to it. So some of my patients are actually getting this in the form of an injection here at Queens once a month. Now, I know Dr. Ogihara is going to talk a little bit about kidney replacement therapy, but that's really the bucket term for what we do when we've exhausted our medical options. So you're probably more familiar with the terms dialysis, palliative care, and hospice. And what we tell our patients is there are different options, but there is no one right option. Okay, everyone has to make that decision for themselves. And if you do decide to pursue dialysis or kidney replacement therapy, there are different flavors of kidney replacement therapy. Now, with the burden of kidney disease becoming greater and greater and the cost of kidney disease rising in the country, we're all pushing to get our patients onto things like peritoneal dialysis or home hemodialysis. So you're probably more familiar with the standard type of blood dialysis where you sit in the clinic or a center, you go about 3 times a week, we take blood out of your arm or through a catheter or IV. We send it through a filter to clean it for 3 to 4 hours, and we send the blood right back to you. In that process, you don't get anyone else's blood, just your blood cleaned because your kidneys aren't able to do that for you anymore. That's one option. We're also teaching our patients how to do that for themselves at home. So we're trying to get you out of the clinics and into your own homes taking care of your dialysis. Peritoneal dialysis is another option in which we put a little catheter or plastic tube into your belly, and we use your belly as a filter to clean your blood out with special fluids. Last but not least, I think I like to tell everybody about palliative care or hospice. Like I said, dialysis is not for everybody. Dialysis will not make everyone feel better. And dialysis is not a cure, right? It's just taking over for your kidneys when they don't work anymore. But palliative care and hospice is also an equally acceptable option. So if you feel that, your kidney disease has made it such that life is really hard and challenging and that dialysis doesn't seem to have made things better, I still think that it's worthwhile to talk to somebody, get more education about it, and if that's your choice, you're welcome to pursue these things. That's it for me, and I'm going to turn this over to Dr. Ogihara.
So she already mentioned about how common the kidney problem is, and the surgeon like me, some may call us access surgeon. When kidney disease, so the kidney is a very efficient, sophisticated filter in your body, but if the kidney starts to get weaker and weaker, and if the kidneys are not filtering enough, you get a lot of symptoms. So unfortunately, I guess prevention is the best medication, the best treatment. But if the kidney starts to fail, and if you need some help, then typically nephrologists like Dr. Izutsu will send a patient to a surgeon like me. Ultimately, the best way, nothing beats your own kidney. Your own kidney is the best kidney. But if your kidneys shut down, then you have to either do dialysis or you have to get a kidney transplant. So we're going to talk about that. I think I can almost skip this slide. It's just that so many numbers of dialysis patients are waiting for transplant too. So hemodialysis and peritoneal dialysis, about 60 to close to maybe 75% of my time I spend in the operating room, I help patients with a kidney problem. My mouse doesn't go there. Hemodialysis, typically you go to the center, and then a surgeon like me have placed a shunt or fistula in your arm, and then they use that. You spend about 4 hours, 3 times a week. That's a typical treatment. The blood comes out, goes through the machine, and comes back to you. Peritoneal dialysis on the right side, usually done at home after the initial training, and instead of using your blood, you use your abdominal cavity or stomach region as a buffer, and then fluid goes in your stomach and then drains out. That'll keep your system clean. Transplant, so compared to transplant, if you go to dialysis, you need always some sort of access because your body is not can't excrete the waste products on its own. So the surgeon like me have to either put a stomach dialysis catheter in your stomach, or you have to have a shunt in your arm. The kidney transplant is better way because you receive the new kidney. It's not as good as your own, but the new kidney is going to stay inside of you. So after you recover from surgery, you don't need what is called access. You don't have to have a shunt. You don't have to have a catheter in your stomach, and then you go to your bathroom. You pee on your own. The transplant, you feel better. And also, Dr. Ijutsu listed all this, low and high sodiums and phosphorus. But after kidney transplants, typically you don't have to worry too much about restrictions of the sodiums and phosphorus. So your choice for healthier food, it improves a lot. And also, what happens typically when patients who's been on hemo, especially dialysis for 5 to 7 years, and when your kidney is completely shut down, not making any urine, they're always told by the dialysis nurse and nephrologist to not to drink more than this and that. But after kidney transplant, they have to drink a lot. So you can drink as much as you need. Many patients are able to go back to work after kidney transplant because of the time restraints on the dialysis treatment goes away. And when you're young, you are expected to actually to live, of course, better, but live longer if you receive a kidney transplant. July 10th, there was an executive order from White House to advance American kidney health. So basically, like Dr. Ijutsu mentioned, I think almost 10% of the Medicare expenditure goes to dialysis care. And to support, I think, one hemodialysis beneficiary, it costs a lot. $80,000 to $90,000 of resources go to one person. Hemodialysis and also peritoneal dialysis are very expensive. So instead of sending people to in-center dialysis, it makes sense to have them do dialysis at home and preferably receive kidney transplant. So this is not a comprehensive summary of the executive order, but I think some of the visions, I think, include to decrease hemodialysis, increase home dialysis, kidney transplant, and also they mentioned they want to encourage artificial kidney, and also increasing available kidney organ utilization. I think there was a recent CNN article that America, I think transplant surgeons like me, we discard about twice as many as organs compared to surgeons in France. So there will be more pressure for the American transplant surgeons not to waste donated kidneys, to use as many kidneys as possible. And also, best transplant kidney comes from the living donor donation, so we like to promote that too. Good news is that the number of deceased donors are increasing every year. This is the United States national. About 10,000 donations happened last year, and as a result, more than, I think, about 15,000 kidneys were donated through brain deaths and cardiac deaths from the deceased donors. So these numbers are increasing every year, which is a very good news for patients with chronic kidney disease. This is the local data. The Hawaii, we average ranging between 30 and 40 every year. About 30 to 40 organ donations occur in the state of Hawaii. Compared to United States as a nation, Hawaii, this is data from 2018. So Hawaii has about 1.4 million population, and the Queens Medical Center is the only transplant center. But this has nothing to do with the lawsuit between Kaiser and Queens Medical Center. But Kaiser patients, they go to mainland hospitals for kidney transplant. So we only serve about 1.1 million population. And 2018, we had 55 kidney transplants. We performed 55 kidney transplants. Among 55, 48 were from deceased organ donors, and 7 were from living donors. If you compare the ratio per million population, the number is a little bit lower than mainland U.S. As a country, United States, we performed 65 kidney transplants per million population in the year of 2018, and Hawaii performed a little less. So we are working hard to get these numbers up. The team, the transplant team in Hawaii, the first kidney transplant, this was recently celebrated both at the Queens Medical Center and also at St. Francis campus too. But Dr. Livingstone Wong performed the first kidney transplant on August 9th, 1969, almost exactly 50 years ago. So since then, more than 1,000 kidney transplants have been performed, and we typically perform 40 to 60 kidney transplants a year. We have been doing this at Queens since 2012. Let's say when you go on dialysis and then your kidney doctor recommend, okay, well, let's try transplants. The most frustrating part is that the numbers of organs are fewer than the patients who are waiting on the waiting list. So they always ask, okay, what's the waiting time? You know, typically in this country, if you need a treatment, you don't have to have a waiting time. If you need a cancer treatment, usually you get to see a cancer doctor right away. If you need this medication, you get this medication right away. But the kidney or organ transplant itself is one of the few area in medicine that resources are limited, and you have to have some waiting time. The average waiting time is between 3 and 4 years currently in Hawaii. It depends on your blood type and tissue type, and it depends how many years you have been on dialysis. And hopefully, or preferably, you get to know about transplants even before you start dialysis. But unfortunately, let's say if you've been on dialysis for 5 years, and if you refer to us, then you have already collected 5 years on waiting time on on a dialysis. And also depends how many donors we have every year, and also transplant census criteria. So to have a successful transplant, like not everybody is for dialysis. The same way, transplant is not for everybody. You have to have certain levels of reserve to have a successful outcome. So transplant's better than dialysis in general, and in the transplant, because waiting time, if you go on the waiting list to wait for deceased organ, somebody who passed and wanted to donate, those are the typical source of deceased organ donor. But if you have somebody around you to be able to donate the live kidney, that's the better way, because you don't have to have a waiting time. But not everybody can donate. At least the donor, if you want to introduce this idea among your family members and friends in your circles, even social network. The minor cannot donate yet in this country. The donor has to be adult, so that everybody knows that they're making their own decisions. And the donor obviously has to be healthy and not any pressure, under the pressure from financial or family pressure. And also the donor have to really understand the risks and the benefits of the donation process. So we very carefully review all these. The donor doesn't have to be biologically related to recipients. So let's say if you're on dialysis, you don't have to necessarily ask only your siblings, parents, and children, spouse, significant other, or even friends, co-workers, sometimes stranger, could donate the kidney, and then we have a very good outcome. In terms of living kidney donation, we've been doing this about 30 years, and we just did, I think, 300 living donor sometime this year. And since 2007, we used to make about 4 to 5 inch incision to do a traditional kidney removal surgery until 2007. But since then, we switched over to not a laser surgery, but minimally invasive or laparoscopic approach, so the smaller scar surgery. And since then, we have done more than 100 laparoscopic surgery that way. Again, we carefully examine the suitability if the donor can donate the kidney safely or not. So when you, let's say, ask around, somebody who is already diagnosis of diabetes, typically diabetic person cannot donate. And if you are too overweight, we don't recommend. If you have some substance abuse issue or psychiatric issues, if you have severe lung disease or heart disease, blood clots problem, or active infection like hepatitis C, HIV infection, you may disqualify. And also if you have any active cancers, we don't recommend those patients to donate. Let's say if you're blood type O, and then if your spouse is blood type B, and then spouse is interested to donate the kidney to you. In this country, typically we don't we call this incompatible, but blood type B to O is not compatible. The blood type O recipient have to have a blood type O kidney. On the other hand, if the recipient, dialysis person is blood type AB, then you don't have to look for AB donor. You can get a kidney from O or B or AB. Any blood type can donate to a person with blood type AB. But let's say if your spouse and you, or your donor, if the pair is not a compatible pair, then we participate in the national exchange program, and we have done this way three donations. So we will computer matches the another pair in another transplant center, and then the donor from here, your loved one could donate to somebody in, let's say, Colorado, and then the similar, let's say, couple in Colorado, they will receive your donor's kidney, and then they can ship back their recipient's donor's kidney back to us, and it's been successful this way. Since I'm a surgeon, I always put this slide at the end. This is the picture of the first successful kidney transplant, I think December 23rd of 1954. The hospital name was not a Massachusetts General Hospital yet, but it was done in Boston. Dr. Joseph Murray, he was not a kidney transplant surgeon because there was no really a profession of kidney transplant yet. He was a plastic surgeon. He performed this, and he later got awarded the Nobel Prize. Identical twin, Ronald and Richard, were the donor and recipient. The recipient lived several years. The donor, I think he was the pretty much first living kidney donor. So he donated in 1954 one of his kidney to his identical twin. He passed in 2010, so he lived 56 years after kidney donation. That's one good example that it's safe. If you qualify, if it's very safe to donate your kidney to your loved one. So this is my last slide. Before, okay, so I think next would be the guest of honors, right? Okay, I think so we will have the main part of this tonight's event now, but Miley Reddy, she's a nurse and patient care coordinator at Queens Medical Center Transplant Center. She will introduce our guest of honors.
Real quickly, before we get to Miley, I want to let's give another round of applause to Dr. Izutsu and Dr. Ogihara. Some very, very important and very insightful information that they provided tonight. So I'll turn it over to Miley.
Thank you. My name's Miley. I'm the Living Donor Nurse Coordinator at the Queens Transplant Center. I'm introducing really our guest of honor today. So you've learned kind of about kidney disease, how to screen for it, possible questions you should be asking, and then possible treatments versus dialysis versus kidney transplant. And I would like to introduce one of our living donors, Dora Young, who donated a kidney to her brother, Alan, a couple years ago now. So these are people who have been through this, experienced firsthand all these decisions and all these issues that some of you are probably feeling as well. So without further ado, I'd like to have them come up and share their story kind of what they've been through. So Dora, our donor first. Okay.
Hi, my name's Alan. My sister donated a kidney to me in April of 2014. What happened is I found out that I had a kidney disease when I was about 23. I went to my urologist for kidney stones. And after further studies and after things, they found out that I had a disease called polycystic kidneys. My primary care physician at that point started taking care of me and doing basically everything they listed here in the slides. It was kind of a catch-22. Polycystic kidneys causes hypertension, and the hypertension would make it worse. And so the doctors would have to deal with me in terms of how to manage my blood pressure control, manage my disease progression, monitor my medications, and needless to say, they did a pretty good job, because normally polycystic kidneys cause total kidney failure at about age 30 to age 40. Because of the medical care that I received from my primary care physician, he was able to push off this disease to the point that I didn't need a transplant till I was about 54, 55. It was difficult because the doctor would have to send me to all these various kidney programs. There were these kidney programs that taught me how to take care of myself, taught me how to manage everything. I'd attend these. He would send me to a nephrologist, so he would monitor me to make sure I was staying healthy, to make sure I was eating the right things and doing things like that. I kept this disease a secret to everyone. Uh, I didn't let anyone know, even my parents. I would tell them, everything's okay, don't worry, it's all right. And only like my wife and even my son didn't know how bad it was. It would progress further and further. I was up to stage 5 of my kidney disease, and I was about 6 months away from dialysis. I had resigned myself to the fact that I would be on dialysis for the rest of my life. My doctors had put me on the UNOS transplant list, meaning I was on the transplant list across the mainland. I had already made my arrangements with mainland hospitals in case something came up. They would be able to contact me, so if I needed a transplant or anything like that. But I understood the implications that it would be about 4 to 5 years if anything would happen. I had just resigned myself that I would be on dialysis for about 5 years. Like I said, I didn't let anyone know. No one at work knew about it. My wife knew about it. My son didn't know about it. I tried to keep it a secret to him so he wouldn't have to worry. My parents, I didn't let them know about it so that they wouldn't have to worry as well. I just kept it to myself. And then it came down to the point of asking for a living donor. And it was hard for me to ask someone, can I ask you to give me a kidney or anything like that? So I basically didn't ask anyone. I never asked anyone. I just resigned myself that I was going to wait till a deceased donor came around. During that period of time, I don't remember exactly what happened, but then my sister called me up and she asked me, how am I doing? What's going on? And I basically told her, no, it's pretty much at the end stage. I'll probably go on dialysis in about 6 months. I'm going in for final check for a shunt in a couple months. I was expecting to go to the normal procedures in terms of figuring out how I'm going to do dialysis and all those other things. And then my sister told me she would donate a kidney to me, and I didn't want it. I just didn't want it. I just couldn't accept the kidney from her. I didn't want her to put in any danger. I just resigned myself to be able to just work and wait until a deceased donor came around. It took me several calls. My sister kept calling me up and saying, no, I'm ready. I can donate a kidney. I can donate a kidney. And I kept saying, no, no, no. It just kept going on, and we finally came to agreement that I finally accepted it from her. It took a long time for her to convince me to take the kidney. So we underwent all these classes. We went under the tests. We met with the transplant team. We met with all the different things to make sure that I was compatible and that she was compatible for me. And it worked out, that everything worked out fine. She could donate to me. We underwent all the tests. We underwent all the various meetings with the doctors, with the treatment team, with everything. And it was successful. In April of 2014, I got the transplant. It took a number of it took a number of months to go through all the regimens, to go through all the medications. We continue to take medication. I continue to take medications on a daily basis. We've gotten into a regimen that I take my medications at a certain time. We have to eat at a certain time. I've been able to adapt my lifestyle to that. The team at Queens, the transplant team, is very good. They prepare you very well for it. They prepare you for it, they monitor you through it, and they monitor you after it. I still see my nephrologist 4 times a year. I come to Queens after 5 years, I still see them yearly to monitor me. They continue to monitor my status on a regular basis. One of the things that after you finish with the transplant, you end up feeling very good. You end up feeling so good that you think, no, I don't need these medications. You end up feeling so good that I don't have to follow any of these other things. I can just do anything I want. And I've heard people that they felt so good that they stopped taking their medications. They stopped taking their anti-rejection medications because they felt so good. But because of that, they ended up losing their kidneys. So one of the things that the transplant team here is they make sure that you follow the regimen, you understand the regimen, you understand how to preserve your kidney, because this is a gift. It's a gift that is so precious, you don't want to lose it. And they monitor you, you just have to follow what they say. You end up living a really good life, you feel really good. And it's just, I think they've done a really good job in terms of making sure that transplants remain successful in you and then you're able to live a healthy, happy life.
So for me as a donor, I decided I was going to be a donor when I was in my 20s, when I found out Alan had kidney disease. And so, like Alan said, I would always ask him from time to time, how are you doing? How's your kidneys? And he would, like he said, he wouldn't tell anybody. And he would say, I'm fine, I'm stable. And so I told him, I said, if you need a kidney, if you need me to do a transplant, just let me know. And he goes, no. I don't want to take a kidney from you. I'll take it from a cadaver, but I don't want to take it from you, because he didn't want anything to happen to me. So I didn't push it. But every now and then, you know, I could see that his health was declining, and his tummy was getting bigger and bigger, but he wouldn't say anything. So again, I would ask him, you know, how's your kidneys? And it came to a point where he says, you know, it's not, you know, I'm not doing well. And he said he was going to put in a shunt for dialysis. And I said, no, I want to donate a kidney to you. And I didn't want him to go on dialysis. So I just told him, just tell me what to do and I'll do it. And I was relieved to find out that he finally accepted. And so Miley from the Queen's Transplant Center called me, and I went in for testing. So I did all the testing, echocardiogram, CT scan, blood tests after blood tests, and that was in December of 2013. And in January of 2014, I was approved to be a living donor. So we had our surgery April 21st, 2014. And I'm just glad that we did it, and I can see that, you know, he's living a healthy life. And for me as a donor, you know, people ask, you know, how has your life changed? And for me, it's really hasn't changed. It's made me more aware of what I put into my body. So I drink more water, which I never used to do. And you just watch what you eat. I don't have any restrictions as far as what I eat, but, you know, I always take everything in moderation. And so I go for my annual checkups to make sure that my remaining kidney is working well. And the Queen's Transplant Center, they follow up with you at 6 months, 1 year, 2 years post-kidney donation to make sure that after donation you're on your way. And then again, you see your primary care physician after that.
Alan, if I may ask you, since the kidney transplant today, how do you feel today?
Oh, it's incredible. Lots of energy. I feel great. All my nephrologist sends me for tests every 3 months. So I see them 4 times a year. All the tests come back normal. Everything's great. I'm able to exercise. You monitor your diet. There's some certain things you don't eat. Unfortunately, you can't eat the poke anymore. You can't eat raw fish. So those are the main things. But you just eat a healthy diet, something that will keep you healthy. You don't go nuts on everything. But it's been incredible. It's amazing.
And Dora, today, how do you feel?
I feel great. I feel like I still have 2 kidneys. You can't tell. You know, people say, "Oh, do you feel like you're missing something?" And it's like, no. So, and you know, with going through the process when I first decided to donate a kidney, you know, my husband was supportive and my kids were supportive, and they said whatever you want to do is fine. So I was lucky to have the support of my family. And, you know, nowadays with everything on the internet, people tend to look and research everything on the internet. But honestly, in my case, I didn't do any research. I kind of trusted the Queen's Transplant Center. And I just said, just do what you need to do. And I'm going to just trust that you decide if I'm going to be a candidate for a living donor. And so I didn't go haywire and go through the internet and search for all that information. So I kind of just trusted the Queen's Transplant Center.
For both Alan and Dora, for people, you know, in the audience that may be thinking about a transplant, or they may know someone or a loved one, or they may be in a similar situation pre-transplant, do you have any advice, any suggestions, any recommendations about for the audience, for both as a recipient and a donor?
As a donor, if somebody is willing to donate to you, take it. Because if they really didn't want to donate, they wouldn't, you know. And for me, to see my brother being able to live a healthy life, you know, is so rewarding. I mean, I just, you know, that's all I could ask for, you know. So I know as a recipient, you always worry about what's going to happen to the donor's life. You know, am I putting their life in jeopardy? But I think with the Queen's Transplant Center, you're going to go through a lot of tests. And if you are not a match, they're not going to let the surgery go through.
If I had to ask someone, it's just my personality. If I had to ask someone for a kidney, it'd be really difficult. It'd be very difficult. The Transplant Center has a way to teach you to ask people how to ask for a kidney, who to ask, how to put it out there among your friends, your families, or whatever, to see if they're willing to do it. Not to put pressure on you, saying that, please give me a kidney, please give me a kidney. No, how to do it in such a way that people don't feel guilty if they don't want to give you a kidney. People who want to give you a kidney will be free to give you a kidney. They feel that they're not pressured to give you a kidney. So those are the things that they taught. They came to us after all the requests I brought up, and they bring out all these different things. They bring out all these papers. They bring up all these counselors to you to ask you, to tell you, to teach you how to do things. And one of the things is how to ask someone to be a kidney donor. It's hard. It's very hard to do, and that's why I couldn't do it. That's why I had resigned myself to be on a list for a cadaver from a deceased donor. But the Transplant Center teaches you and tells you how to do it so that no one feels obligated. No one feels obligated to give you a kidney or anything like that.
Thank you, Dora, and let's give them a round of applause, please, for sharing their story. I'm sure it's not easy to share their story in front of you folks, but the fact that they've taken the time and the energy to share with you their experience is just very heartwarming. I want to make sure I open it up to questions, because I know there may be some questions. So if I could have Dr. Ogihara and Dr. Izutsu come up again, once again, please. If you have a question to either one, to Dora, to Alan, to Dr. Ogihara, or Dr. Izutsu, they'll be up here. There's microphones in the back with the volunteers. They have the yellow shirts on. You can just raise your hand, and we'll bring their microphone to you, and you can ask your question to either one of these four speakers. Does anybody have any questions? Yeah? Okay. Right behind you. hang on. Yeah, you have a question? Raise your hand, please, if you have a question to ask. Okay, and if you could just speak clearly into the microphone so everybody can hear. Thank you.
I think I have two questions. Number one, you are the only one brother, sister, nobody, so you are just two of you.
Yeah, just the two of us.
Two of you, yes.
I'm sorry, real quickly. I'm sorry. Can we turn the microphone on so that everybody can hear this one?
My first question
Oh,
was.
is it on? It was on?
All right, check.
Can we? It's on? Okay, everybody can hear?
Check.
Okay, my first question was whether or not they are the only brother, sister, nobody else in the family. Am I right?
Yes.
That's correct.
Yes, I can understand you are feeling better, as a sister. You don't want to see your brother suffering. Okay, so you answered my question. My number two question.
Okay, I'm sorry. We'll get the other microphone right away, please. Thank you very much. Sorry for the technical difficulty.
Testing. Can you hear this?
No.
Both batteries are dead.
Okay.
Go ahead.
Go ahead. Shout. Go ahead. Shout, please.
Dora.
$14.
2014. 5 years.
After 20, 30, 40 years later, so I like to ask doctors the rate of success, the donor will live happily, as long as you live your life, has the situation, has the way, eating properly, exercise properly, all that. That's some doctors can answer my question, because I have not been interested in kidney like that, but I like to know. So you were told like that, as long as you live a healthy life, there will be no problem.
There's no guarantees in life, but I live a healthy life even before surgery, and now, I don't smoke, I don't take drugs, I don't eat a whole lot, and I try to eat healthy foods, and now I drink a lot of water. So hopefully that will take me to, who knows when, but I feel good, and I go through my annual physicals every year. My blood tests are good, so hopefully it continues.
I think your question is the long-term outcome of the living donor after kidney donation. It depends on what you read, and if you medical literature savvy, and if you're internet savvy, you can find articles to mathematically calculate the risk. And it depends on your age, gender, either African American or not. So obviously, if you donate at your younger stage, your risk of getting a kidney failure for the rest of your life, in your lifetime, is higher because you live longer. The very simple answer I present to a patient like not patient actually, the donor candidate like Dora, is that generally speaking, let's say if you haven't had any diagnosis of kidney problem, but if you get a kidney failure, the chance of kidney failure is about 0.1% in general population. About more than 100,000 American people have donated their kidneys to loved ones over the last 50, 60 years. And about 130 or so donors, like Dora, have gone into renal failure after donation. So the risk of getting a kidney failure after donating your kidney is about 0.1%. That's a simple number. So if you don't go into a mathematical model, then you can say, okay, the chance of getting kidney failure is 0.1%, even if you don't donate a kidney or even after you donate a kidney. In a way, we only take the donor or person who we don't expect to have any higher chance of getting kidney failure. So if we are worried about, we don't recommend. The donor didn't have anything, and then she has, I think, very, very careful not to catch any new problems that'll hurt your kidneys. So that answer your question?
Another question is that why do we have two candidates? One is the new, another one.
So some questions you have to keep it beyond this life, and then when you face your creator, you will ask. But definitely two kidneys compared to, I do a liver transplant too. To take out part of the liver from living person and then split into it and then use one of it, you use a part of it to somebody else is 10 times higher. I mean, the more difficult operation compared to take one out of the two kidneys. So somehow we have been designed so that we can share one.
Okay, I'm sorry. I want to get to some of the other questions too, please. Anybody else have a question? Okay, one right here. Anybody else on this side have a question? Yeah. 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 Yeah, right here.
Are a high stress level and extreme social isolation risk factors as well in the development of kidney disease?
I think it depends, because a lot of those psychosocial factors can sort of play into development of chronic diseases in general. I think one of the problems is the development of high blood pressure. So generally speaking, patients or individuals who tend to remain isolated, who have high anxiety, high stress, a lot of them can develop high blood pressure along the way. It's not to say more than the general population, though. It all depends, on other lifestyle factors as well. So even if you tend to be more socially isolated, that's not to say that you'll develop kidney disease more often than or that your likelihood of kidney disease is higher.
Anybody else? Right? Okay.
Doctor, could you briefly describe the surgery that occurs when the donor gives the recipient the kidney? Is it a long process or?
The surgery to remove one of your healthy kidney typically takes 2 hours and a half, and it's under general anesthesia. And hospital stay is 2 nights. We do this Monday morning most of the time. Most donors go home Wednesday afternoon. And full recovery will take 2 to 4 weeks. Surgery is very safe.
Any other questions? Raise your hand, please. Raise your hand high. We have some over here. Right here? Yeah. Go ahead.
This is a question about diet. I don't have kidney disease, but I do have high blood pressure and pre-diabetic, and I worry about sugar and I worry about salt. But now I'm wondering whether I have to worry about potassium and phosphorus levels. I mean, what is this thing? I mean, I never heard about this, so I'm just curious about, do I have to watch those kinds of things too if you don't have a kidney disease, but you do have high blood pressure and pre-diabetic?
So I have a very small subset of patients who actually have normal kidney function, who have some lab abnormalities like you're talking about, so high potassium, high phosphorus. But that is completely isolated to some inherited issues with those types of chemical imbalances. Generally speaking, if your kidney disease is early stage, or if you're talking pre-diabetes, not even having kidney disease on your radar yet, it usually is not a problem. It's easy enough to have your doctor print you out a copy of your lab results, and then you'll see the potassium and phosphorus come up, and they'll give you normal ranges. And like I said, in a very small subset, it's actually problematic, but I wouldn't expect it. The salt and the sugar is enough.
Okay, anybody else have any other questions?
My question is for either one of the doctors. There was a mention about artificial kidney, and also I read about a 3D computer-generated organ. Is that what you call the artificial kidney, and how is that coming?
The artificial organ has been studied, and I think there are two active. It's not experimental, but the preliminary. It's not everyday clinical use, of course, yet. But University of San Francisco and I think at Mayo too, they are investigating the artificial kidney. So basically, it's a mechanical pump that can go into your body. Like artificial heart, always the issue is the blood clotting. You know, the natural organs, you don't need to take the blood thinner. But you know, if you put the machine in your body, there's always an issue with a clot. So it has not been completely come to, okay, well, it's going to launch next year, you know, something like that. Also 3D printing, more structurally simple organs, such as, let's say, you know, the ears and nose and bones, and they don't have to produce, they don't have to filter and produce urine. But the liver and kidneys, they have to have a really sophisticated function itself. So 3D printing, eventually, then nobody has to donate a kidney. We don't have to take immunosuppression. All the surgery is 7:30 in the morning. That's great. But we are not there yet. So when my patients ask me the similar questions, you know, I don't think it's going to happen a couple of years yet.
Okay, any other questions? I think the gentleman here had a question. Go ahead, sir.
Generally speaking, to what extent does insurance cover the 2 operations involved in a live donation?
My insurance covered for me as well as my sister's medical care throughout the whole thing. I had double coverage. My wife had coverage for me and I had coverage, and so it was basically it covered everything. All the pre-testing, post-testing, and everything that necessary was taken care of by insurance.
Okay, any other questions? Yes, in the back there.
Dr. Ogihara, I have 2 18-year-old donors who wants to donate their kidneys to me. They're both my granddaughters. They want grandma to get well. So is there a process that you or the people involved in the transplant would put us through some kind of education to understand and learn on both sides? Because they're females, 18 years old, they have their whole life ahead of them, but they want to give grandma a kidney of theirs, and they want this, and I'm like him, telling them no need, I don't want. But I've learned a lot from their testimonies tonight that this is the reason why I'm asking that question. Would my grandchildren who want to be a donor, donate one of their organs to me, would they be compatible for me to have that transplant? And can they be educated as to what they're giving up?
Yeah, of course, they can be educated. I think the first step is that the recipient, so the has to qualify for kidney transplant. So you go through that. And also, you could wait until you're on the list, or you can have one of your granddaughters work at the same time. They have to call the transplant center. Even if you give me their phone numbers, I'm not supposed to call them up. Hey, can you donate? So they have to call transplant center, and then Miley will take care of it. But there is a screening process that they have to qualify, and then we will check the blood test and urine test, make sure it's compatible, and then after that they have to go through quite a bit of process. They're 18, right? Not 17. Okay, all right. Yeah, have them call us.
Are there any other questions? Yes.
Oh, me? Oh, sorry. I can speak loud. I just want to know the eldest recipient of kidney donation.
There's no age cutoff. Hawaii, the oldest recipient was 78.
Oh, wow. And also, I have another question. Why did the recipient not have dialysis before the kidney transplant? Was it a choice or was it medical advice?
I was due for dialysis in about 6 months.
Oh, okay.
So they had scheduled me to go to get evaluated to put in a shunt. My GFR had dropped to 15 to 16 at that point. So my nephrologist had scheduled me to go to get my shunt put in. We had already had all these things taken care of so that I was going to go to dialysis. I was at the point of either going transplant or dialysis at that point.
Oh, okay.
Yeah.
Thank you.
Any other questions?
I've got a question for the surgeon. Did you say the transplant?
Hang on. He's coming with the microphone right there.
Did you say the transplant was done through laparoscopic operation?
The donor surgery is done with the help of a laparoscope, not the recipient.
Oh, I see. Okay. I see. Okay. Understood. Thank you.
Question? Anybody else? Anybody else? No questions? Okay. Let's give one more round of applause for Dr. Makoto Ogihara, Dr. Christy Izutsu, Alan Young, and Dora Young for taking the time to come out tonight. We want to thank everyone for attending, also to Val Milstein and Patty Sokol for providing sign language interpretation tonight. And also, please thank you to the National Kidney Foundation and the Queens Transplant Center. They were in the lobby earlier this evening providing some very important information, so thank you for their efforts. And mahalo to our Queens volunteers, Jolyn and Abigail. So next month, our next Speaking of Health lecture here at Punch Bowl is entitled Understanding the Importance of Good Prostate Health. So having a healthy prostate is vital for good overall men's health. Now, according to the American Cancer Society, the risk of developing prostate cancer rises rapidly after age 50. However, not all cases are cancer-related. We'll learn more with Dr. Robert Carlisle, who's a urologist at the Queens Medical Center. That's Wednesday, September 25th from 6 p.m. to 7 p.m. Again, it's free here at the Queens Conference Center. Again, we want to thank everyone for attending the Queens Medical Center Speaking of Health lecture. Don't forget to get your parking ticket validated in the lobby before you leave and drive home safely. If you do have any additional questions for either Dora, Alan, or the doctors here, they will be hanging around for a few minutes to answer some of your questions. Okay? Thank you very much and drive home safely.